Good evening, and thank you. Want to thank them as New Zealand MS Society for having invited me to share with you some concept about hematopoietic stem cell transplantation for multiple sclerosis. You see here there is a logo of the European Society for Blood and Marrow Transplantation. Most of the data that I will present has been produced within the context of the cooperative studies of our societies. However, talking about hematopoietic stem cell transplantation, I think I should very briefly remind or recall a few concepts about what is a stem cell. So a stem cell, you can see the definition in the left panel, is a cell that has the ability to continuously divide and differentiate into various kinds of other cells. So in other words, a stem cell can duplicate and maintain a pool of stem cells in our body for all the lifespan of our life, but also to differentiate and create different types of cells. It is like, if we can make this comparison with building a house, and building a house like the fetal life, the intrauterine life, after in the development of the embryo, there is the need of a huge amount of materials. Like in a house, you need the walls, windows, pipes, and so on. But also, when in the adult life, we need a continuous maintenance of our body, as well as in a house. We have stem cells in the heart. We have stem cells in the bowel to replace all the cells which are continuously lost with the activity of this organ and tissues. But in particular, in the bone marrow, which is the inner part of each bone, you can find a number of stem cells which can provide some reservoir for many tissues, the bone, cartilage, fat cells. But there is a particular, a specific type of stem cells, this one, hematopoietic stem cells, which provide a reservoir to produce the cells of our blood for all our life. So from these cells originate the red cells, the platelets, and also the white cells, and all the subtypes of life cells which constitute our immune system. So we are talking today about so-called autoimmune disease, so a disease in which the immune system, and in particular some of these cells, some clones of these cells, lost their capability to recognize what is called, the immunologists call the self. That means that they lose a sort of self-control and they start to attack some part of our bodies. In the case of multiple sclerosis, some specific cells in the central nervous system. So, when the bone marrow has failed, or we need for some reason either to replace it or to administer a high-dose chemotherapy, we do a hematopoietic stem cell transplantation. Given that for many years the only source of stem cells was the bone marrow, it is usually called, and still called, bone marrow transplantation. It is the same thing. It is not a tissue transplantation. It is a transplantation of stem cells. How do we do a hematopoietic stem cell transplantation? We administer, first of all, a high-dose chemotherapy, the same chemotherapy that are used for cancer. And we increase the dosage of this chemotherapy in order to erase the bone marrow, all the cells which are inside of the bone marrow, and therefore also the immune system of the patient. After that, we have administered the chemotherapy, which is called conditioning regimen. We take the stem cells of the graft and we infuse them like a blood transfusion. The stem cells circulate and go across all the tissue and organs, but then they are recalled into the bone marrow. They settle in the bone marrow. They restart to proliferate and regenerate the tissue of the bone marrow. And therefore, at the end, usually after a couple of weeks from the infusion of the stem cells, the bone marrow restarted to produce the blood cells. So therefore, after the conditioning regimen, after the chemotherapy, there is a period in which the patient is extremely susceptible to infections, needs transfusions, needs a particular care, has to be in a protected environment in order to prevent infections. Then the white cells start to raise again in the blue line, and the patient can be discharged. When you use the stem cells of a healthy donor, you do an allogeneic transplantation, which, if you like, it is a real transplantation. You transplant an organ to a donor, to a patient. But there is a particular situation in which you can use the stem cells of the patient. This is called autologous transplantation. In this case, the stem cells are collected before, usually 1 month before the transplant. They are collected through a machinery which take the stem cells mobilized by the bone marrow into the blood, and all the rest is reinfused in the patient. Just the stem cells are collected, kept in a bag and frozen, and maintained at a very low temperature, usually in liquid nitrogen, minus 196 Celsius degree. And they can maintain their biological properties for years under these conditions. So then we administer the conditioning regimen, then we thaw the stem cells and we infuse them like in allogeneic transplantation. It's quite important to understand the difference because when we started to do the transplant for MS about 20 years ago, we learned that the most reliable and safe procedure for this patient is the so-called autologous transplantation. So we don't take the cells from a healthy donor, but we always use the cells of the same patient. Hematopoietic stem cell transplantation is a very well established procedure worldwide. In this paper published 2 years ago, a retrospective analysis of the World Bone Marrow Transplantation Society reported the first 1 million of patients who received this procedure, either autologous, red line, or allogeneic, blue line, and this is a combine. And as you can see from this data, which has been, they have collected the data from all the national registry worldwide, the use of hematopoietic stem cell transplantation is not only well established, but it's in continuous growth. But it's quite important to know that actually most of the patients transplanted are affected by cancer, in particular blood cancers, so leukemias, lymphoma, multiple myeloma. In this small yellow slice, there are the autoimmune disease. These are the data of the European Bone Marrow Transplantation Society. So, bone marrow transplantation, to make it shorter, is a very well-established procedure. The indication of multiple sclerosis and other autoimmune diseases, such as lupus or scleroderma, are a rare, a sort of niche, a rare indication. There is no time to understand or to explain why we do the stem cell transplantation in multiple sclerosis. This is just a number of papers reporting a number of scientific studies on the mechanism of action of the transplant in multiple sclerosis. Basically, we started because in the experimental model in the 70s, some scientists, in particular in the Netherlands and in Japan, provided the evidence that autologous transplantation could be effective in an animal model of multiple sclerosis. Then a few cases of patients diagnosed with leukemia and who received a transplantation for the leukemia also had, very rarely, but it had also a coincidental multiple sclerosis or another autoimmune disease. And this gave us some hint that the procedure could be useful for this patient. I just want to recapitulate this concept in this slide, which reminds you that a patient develop an autoimmune disease because they are genetically predisposed to do it. So there is in all the patient, if you make a gene profiling, you find a number of genes which shows that that patient, under some condition, usually infection, viral infection, or other environmental factors, can trigger the disease and shift from a latency phase to the phase of the overt disease. What we want to do with the autologous transplantation is to reset the immune system. So we destroy, erase, let's say, the immune system of the patient with the chemotherapy, and then we leave that the immune system of the patient regenerates starting from the stem cells that we have collected before. In this process of regeneration, let's say the concept is the immune development would get a second chance to go down the right path. It's like rewinding the immunological clock to a virgin state. So we keep back the patient to a state of, let's say, that's before the development of the disease. Clearly there is a risk that the immune system does the same mistake. So there is a probability of a relapse, but we didn't know which could be the incidence of relapse following the transplant when we started. And this started here, exactly 20 years ago, 1997. This is the first scientific report of 15 patients diagnosed with MS and transplanted because of their MS. That happened in Greece. The real pioneer of this adventure is Athanasios Fassas, doctor on the right, which is now receiving an award from the president of the European Bone Marrow Transplantation Society for his pivotal role in this procedure. And he reported 15 patients with a progressive MS. So he concluded that it could be feasible. It does not aggravate the aggravated disability and seems to offer a clinical benefit. But that was at the very beginning. Where we are now, this is the last update of the our registry, the registry for the autoimmune disease of the EBMT, European Bone Marrow Transplantation Society, which is the largest registry worldwide. We have more than 2,000 patients reported for all the autoimmune disease, but about a half of them were diagnosed with multiple sclerosis. So in our registry we have more than 1,000 patients transplanted for MS. How many transplants do you do, and what is the trend? This is the EBMT trend, but it's similar also in North America. Even if in Europe probably we have the most prominent activity worldwide. You can see that these are the years, these are the last years, so since the very beginning, you see there is an increasing trend for the use of stem cell transplantation in MS. Despite the availability in the market of a new, innovative, and effective drug for MS. The reason is, despite this new, very effective drug, there is always a subset of patients who do not respond adequately, or they need to have an immunosuppression too toxic, let's say, to be maintained for years. And therefore, for this patient, most of the neurology now consider the transplantation as a clinical option to rescue this type of patients. In this cartoon, there are also not only the total number of transplant, but also the event of the treatment-related mortality. When we started, the transplant was perceived by the neurologist as an extremely risky procedure, very expensive, with no indication about its efficacy. And actually I have to say that the toxicity of the procedure in this patient, despite the low number, was considerable. It was about 5% in the first 5 years. Now you see that this dark blue bar are decreasing, and the transplant-related mortality in the last 5 years is around 0.2%, so below 0.5. The reason for this is both a better selection of patients, so we select patients less advanced as at the beginning, and also an improvement of transplant technology. So we can consider that today, irrespective of the transplant technology, the risk of irreversible toxicity is below 0.5%, which can be much or few or little. It depends on the way you say. Don't forget that with the new drugs, there is some risk, especially with Tysabri, for instance, so there is the risk of PML and Lemtrada. Before going ahead, I want to emphasize one important concept. All these patients were transplanted because they were shown resistant to the conventional treatment. So they have already failed previous treatment. Here before 2004, probably most of them had received mitoxantrone, we don't use anymore, cyclophosphamide, steroid, and so on. But for the patients which are being transplanted in the last 5 years, most of them had failed at least Tysabri, or more recently, Tecfidera. Too early to transplant patient after Lemtrada, definitely even too early for ocrelizumab, which is the last one just approved by the FDA for the MS. But in a way, the concept is that those patients were transplanted because they were resistant to approved treatment. Where does the transplant is carried out? At least in our registry, see that there are many centers which has accumulated a considerable experience, say more than 30 procedures, and I'd like to point out to Sydney St. Vincent Hospital, which reports to our registry. But in the last 5 years, you see that this, at least 6 centers have performed more than 25 transplants, so they have accumulated a considerable experience. Our center is still the center in Europe with the largest experience. This is a bit technical, but I didn't find a way to describe more precisely the outcome. So let me explain how this, what this curve or this graphic express. This is the moment of the transplant, and this is the time after the transplant. Here we have months, that means about 5 years. 5 years again, and 5 years more or less in most of this curve. The curve expresses the probability of being surviving without a progression of the disability. Let's say if you have 80% here, that means that this group of patients have 80% of probability, so it means 80 patients over 100, to be surviving and not worse, not more disabled as compared to the moment of the transplant. And this is the Swedish registry showing that patients transplanted early in the phase of disease, within 5 years from the diagnosis, are doing better than patients transplanted with after a longer interval. This is the Italian database, 72 MS patients, all treated with the same transplant technology in different centers. And you see that the patient, you're probably familiar with the concept of the relapsing remitting, so the initial phase of the disease, when the patient have relapses, they need to be treated with a steroid. And the secondary progressive phase, when the relapse become more and more infrequent, and the disability progresses slowly. The same concept is reported in these two registry analyses. We have a higher number of patients. We have the bias of a registry, a retrospective analysis in the registry. Anyway, you see here that these patients in the relapse and remitting phase are doing better than the patient in the secondary progressive phase. The same in the last panel, which report a combined analysis of American and European registry with patients which had at least 5 years of follow-up. So we wanted to see in the long term which was the effect of the transplantation. So we picked up from the registry only the patients for which we had more than 5 years of follow-up and available data to assess the long-term outcome. And once again, you see that relapsing remitting are doing better than secondary progressive patients. This has been published this year. So the first concept is transplant is effective because it can rescue many patients which were unresponsive to the conventional treatment. Patients transplanted in the early phase of the disease are doing much better, which was expected. The transplant, this type of transplant with these stem cells, is not a regenerative procedure. We cannot repair, unfortunately, all lesions. We can shut down the inflammation. So as long as we have flare inflammation in the early phase of the disease, we can stop the inflammation, but we cannot repair the damaged part of the brain. Some patients which develop, let's say, some new lesions recently can show some capability to repair, not because of the stem cells, but because in our brain there are a number of mechanisms able to reproduce or to regenerate partially, at least the myelin sheath. And this is even more evident in these very recent papers. This is the Chicago experience. Richard Burt and co-workers in Chicago has the larger monocentric experience. In the last, let's say, 7 years, they transplanted mostly patients in the relapsing remitting phase. The curve expresses the disability, and you can see there is an average decrease of the disability after the transplant. We look at the same parameter variable in the Italian MS database, and we found that actually patients transplanted in the relapsing remitting phase have a higher probability as compared to the secondary progressive phase to improve after the transplant. Not much, but some patients even with 1 point of EDSS. When we compare, we put together the data of the European and American registry, we have a confirmation of this data. You see here, this is the day of the transplant. These are the years before the transplant. In the colored line, there is the disability. And most of patients in the relapsing remitting phase were deteriorating, were getting worse because the disease was not sensitive to conventional treatment. And after the transplant, many patients tend to stabilize or even to improve, which was much less frequent in patients transplanted in the progressive MS space. So, once again, two concepts. The first is that patient transplant is efficient and can provide a benefit mostly in patients in the inflammatory phase of the disease. The second, which is remarkable, is that if you take the data of different centers or countries or registries, these data are always reproducible. The data, the outcome of the patient transplanted in Chicago are extremely similar to the patient transplanted in Italy or in Germany or in Sweden. As a general concept in a clinical research, the reproducibility of data is a strong determinant about the reliability, of course. It's not one center which says it's fantastic and another center that cannot confirm the same data. So we have accumulated now a considerable experience confirming the initial data. This clip show you something. When we talk about the concept of a cure in medicine, we think of a complete cure, so the disappearance of all the symptoms of the disease. This is an MS patient which is just admitted to the bone marrow transplant unit 8 days before the transplant. 15 days after the transplant, she's discharged. And see, she has improved, but she still needs a support to walk. 4 years after the transplant, now she's at 7 years, but I don't have the clip, but she's stable. She can walk definitely better, but she's not completely normal. She still has what the neurologists say an ataxic deambulation, because the old lesion has remained. So we have shut down the flare. She had a recent relapse over here. The flare has not relapsed, so she doesn't have any more treatment. She has never received any other treatment after the transplant. She's stable, but she's not completely returned to the normal. That means that with this procedure, unfortunately, which are able to shut down the flare, which is a lot, because these patients were refractory to the treatment before. They don't need any more treatment in about 80% of cases. But if this patient had accumulated a lesion, a very high lesional load in their brain, we cannot reverse the disability. However, The concept of the selection of the patient is a key factor in the outcome, has determined a change in the approach of the neurologist. At the very beginning, yellow bar, the neurologist addressed to the transplant only patient in a progressive phase. Nothing to do anymore. No more available treatment, progressive phase, let's try the transplant. With time, you see that at least in Europe, now most of patients transplanted are in the relapse and remitting phase, because the concept that I have explained before has become, let's say, widespread in the neurological community. A couple of technicalities. I don't think it's my aim today to get into the detail of the transplant technology, but I see many patients who Google, look at the internet, and read the papers. They tend to ask us to say, do you make in a myeloablative transplant, a lymphablative? Just to say that we have not yet a clear evidence of which is the best transplant technology for MS. This cartoon reports the intensity of the chemotherapy which is administered for the transplant. And we go from the extremely high intensity in case of the Canadian trial, which was published last year in the Lancet, to the low protocol, which is the Chicago and one, let's say, case series that we did in Italy time ago, which is a low intensive treatment. But however, if you see the lymphablation, so the specific activity of the immune system, you don't have lymphablation without myeloablation, and vice versa. This is what we use in Europe. We have been using in Europe largely. What we use still in our center, it is an intermediate intensity. It means that the chemotherapy that we administer has an intermediate toxicity on the body, because we still think that is still the best equipoise between efficacy and toxicity. And when we we look at all the trial published in the literature, 750 patients reported to the literature, and we compare the data reported in the papers, we found again that the only determinant is the selection of patients. So if one patient is doing badly, can take another line of treatment, but it must be clear that if you wait years and years, and then the patient shifts into the progressive phase of the disease, the transplant becomes less and less effective. At a certain point, the assessment of the ratio between risk and benefit that should be at the base of any medical activity become unfavorable. We reject about 90% of the application to our program because the patients are either too advanced, like in this case, too late, we would say, or even too early. If a patient is just diagnosed, has started an approved treatment, is doing well, no lesions, no relapse, why we should take the risk of an aggressive procedure? But if a patient fails a first line of treatment and then he makes a dose escalation and escalate to a more intense treatment and he fails the second line, it's probably useless to try a third line and then the fourth, because with a year that patient might shift into the progressive phase. These are the data from our center, more than 83 patients now, MS patient treated. You're familiar now with this curve. This is the progression, the survival free of progression. So 85% of patients at 10 years are not progressed, not worse than before the transplant, but when we compare with the secondary progressive phase, you see there is a huge difference. And even if we look at the disability, which is 5 as a threshold of patients transplanted with low disability do much better than patients transplanted with a more advanced disability. And if we look at more in depth at the outcome, and we look at not only at the progression of the disability, first factor, to the incidence of relapses, second factor, but also to the onset of new lesion at MRI. A lesion at MRI is a hallmark of inflammation. So if we can look at the best possible achievement that we can have from any treatment, so no progression, no relapse, no new lesions at MRI. Some lesions can appear and not be symptomatic, for instance. This is the NIDA, which is non-evidence of disease activity. It's one of the parameters of the neurologist. We have about 50% of patients, once again at 10 years, 71 at 10 years again, as compared relapsing remitting and secondary progressive. I'm approaching to the end, so relax. So I'm going back to the published data. It's always important to refer to what is published because it comes from journals in which each paper is submitted and reviewed by a referee and can be accepted. The referee can say it is not clear, suggest changes, and so on. So this is an overview of the, let's say, incidence of NIDA, so non-evidence of disease activity 2 years after the treatment, in a number of pharmaceutical trials. These are the placebo, this is interferon, and these are the most updated drug. Natalizumab is, these are pharmacological name. Natalizumab is Tysabri. Alemtuzumab is I will tell you now. Ocrelizumab is ocrelizumab. Alemtuzumab is no, that's Tecfidera is this one. It's one of the things. I will tell you soon. It's an old drug, actually. We have been using it in bone marrow transplantation since 30 years. So the name was Campath, which was Cambridge, but now it was renamed when it became commercially interesting for, I will tell you later. And these are the transplant. So Lemtrada, that's the name. This is Lemtrada. And this is a transplant. At least five studies published with on transplant. The patient here are usually better, I mean much early. Here the patient had a more advanced as an average disability, and they have failed more than one line of treatment. Some of these patients were naive, so never treated at the moment of the trial. And you see here that the transplant seems to be more effective than the conventional treatment in achieving a state of remission free of new lesions at MRI. So, which is the take-home message? Autologous hematopoietic stem cell transplantation results in long-term stability or even in improvement in some patients. Anyway, in a high proportion of multiple sclerosis patients who were shown resistant, not responding to approved treatment. The safety profile is now overall acceptable as compared to 20 years ago. And it should, let's say, to be balanced to the fact that we are in front of a population with a high risk of severe disability, at least in the midterm and long term. However, it is an experimental and aggressive procedure, and therefore should be restricted to trials approved by the competent authorities, and also add in center with a documented experience. I'll go back to this in a moment. It's quite important to remember that compassionate procedure in patients showing an advanced disability must be avoided. If a patient was diagnosed 25 years ago, the last relapse was 15 years ago, every year or every 2 years he does an MRI, and the last new lesion was documented 12 years ago, and the patient is progressing slowly every year, the transplant unfortunately cannot offer any expected benefit. So this is quite important to keep in mind, and therefore this is a paper that we published 3 months ago in a quite important journal, Nature Review Neurology. It is the opinion of a number of experts summarizing what today, according to the, let's say, to the scientific opinion, is the profile of the appropriate candidate for a transplant. Either a patient in relapsing remitting phase or a progressive MS, but for a short period. So a progressive patient who still have superimposed relapse or still have shown no new lesions at MRI, despite the administration of conventional treatment. Ideally, the patient who showed the best benefit are patients with a recent clinical inflammatory activity, either relapse in the previous months or MRI activity, so new lesions at MRI. Statistically speaking, younger patients do better than patients with older than 45. Statistically speaking, patients transplanted early after the diagnosis do better than patients transplanted at a longer time, and at least no longer, we say, of 10 years. They should have low to moderate disability. Actually, all the variables that I have mentioned are related to each other. So a patient with a high activity, many relapse in a short time early in the phase of the disease is usually younger than another patient, is usually in the relapsing remitting phase, and therefore actually we describe a patient, a type of patient in which all these variables are represented. Clearly we have to show that patient failed approved high efficacy disease modifying therapy, preferably not more than 2 lines. This is a concept that I have anticipated before. Many patients fail, for instance, interferon or Copaxone. Probably is too little to accept a patient in a transplant program. A patient should have at least release of 1 escalation, so Tecfidera or Tysabri. But according to what I said before, it's preferable not wait to fail 3-4 lines of treatment, because then time goes on and patients sooner or later shift in the progressive phase of the disease. Of course, there are no patients do not have to have any substantial comorbidities, so they don't have must not have any heart disease or renal failure or so on, and they must have the capacity to give an informed consent. What we should do now to stick to these rules, from a scientific point of view, it is quite important, should be quite important that we should carry out what we propose in this paper. It is a position paper on behalf of the European and American bone marrow transplantation societies, in which a group of experts design the ideal study, which is a study in which we should compare prospectively patients who failed one or more line of treatment, and then should be randomized to receive either a transplant or the best approved treatment in that moment. And in case of failure, so let's say in case that a patient failed, the control arm should be treated with a transplant the other way around. Unfortunately, this type of trial has no interest for pharmaceutical companies, as expected, even because we are running a second analysis of cost effectiveness of transplant compared to conventional treatment. We published a paper almost 10 years ago in which we compared transplant versus mitoxantrone. Mitoxantrone was already an orphan drug at the time, and we found that calculating the direct and indirect cost of the procedure and the treatment, if the patient failed, let's say, had an effective treatment in 5 years from mitoxantrone was more cost effective. 10 years after, the transplant won. But at that time, the mitoxantrone was already orphan, and it cost nothing. If we compare the cost of the transplant now with the cost of the current approved treatment, the most recent, ocrelizumab, Tysabri, and the other one I had already forgotten, Lentrada. Probably, if the patient remain in remission, so with no treatment after the transplant for 2 years, probably the alternative, the drug is more cost effective. But after 2 years, if the patient still remain in remission and doesn't need any more treatment, the transplant becomes even more cost effective. So we are running this analysis in the European societies, and I hope that it will be ready next year, the beginning of the next year. Then we'll try to publish it, and that might also, let's say, raise some interest even in the insurance or health national service. So not only efficacy, but also cost. The last few slides, it's a group of patients, so it's important in the internet era to give some hints on how to try to understand what you can read if you Google stem cells and multiple sclerosis. This is the website of IMS Australia, which has a section on transplantation. Also, New Zealand Society has a section on transplantation. But if you go around, look at the media, you will find many confusing information. And I take this, this is a newspaper, so it's not a chat line, reporting a paper which has been published by a study, Chicago and UK. And they report here, patients who had been wheelchair bound for 10 years have regained the use of their legs. And then the reported declaration, they say, of a statement of Professor Sharrak: since we started treating patients 3 years ago, some of the results we have seen have been miraculous. Now, I know Basil Sharrak, and I honestly doubt as I ever pronounced the word miracle. There is nothing miraculous in bone marrow transplantation. It's just clinical research. What we achieve is what you expected. I have to say that 10 years ago, 12, 20 years ago, we didn't expect such a prolonged benefit. But it's not surprising that if you do that, if you do the transplant, you can have a benefit in a patient with an chronic inflammatory disease. So, but this is confusing. They talk about miracle, and the miracle is something different. So, yesterday, I Googled stem cells, multiple sclerosis, and I found here that the first link is a multiple sclerosis stem cell treatment, StemGenX. Then there are other links which are on Multiple Sclerosis Society. This is the NIH, the American NIH, so scientific institution. But the first one, and it is not an advisement, looks scientific, is of this society, StemGenX. And this is the website. Very well done. Smiling people, cured people, very grateful to StemGenX and so on. Understanding multiple sclerosis, you go ahead and you find the description of what is multiple sclerosis, but then this sentence: over 1 million adult stem cell treatments and continuing and counting have been performed, and many have improved the health and quality of life for patients with unmet clinical needs. Now, if you remember one of my first slides, it's actually true that more than 1 million stem cell transplantation have been performed, but for leukemias and lymphomas, not for MS. And if you go ahead, the second sentence, statement is groundbreaking research related to all stem cell therapy for slowing MS disease and for repairing damage to the nervous system has shown much progress. So it seems there is a lot of research put together slowing MS disease and repairing damage to the nervous system. There are two concepts that are completely different. One thing is try to shut down the flare, and we succeed in doing that. Another thing is to repair all lesions. So in this website, you find usually a mix of true statement, false statement, and this is a way to manipulate the information to let's say, to recruit customers. So what we want to do within our European scientific societies is, given also that patients are now available in traveling across countries, so some centers follow a commercial policy. I always say, if you go to a center, if you apply for a center and they ask you just which is your disease, your name, and tell you which is the cost, but they don't screen the patient to understand whether that patient actually has a high probability of a positive benefit and risk ratio. Maybe that center is following a more commercial policy. You pay and they transplant you. So there is a need also, this it's an invitation to us, for the scientific society to develop a section in our website, in the internet era, to provide policy guidelines accessible to patients. And it is crucial also the involvement of patient societies like yours. So for instance, if we develop this, you as a MS society can put the link of a scientific society to the scientific society, so that the patient can have always an updated information from the scientists. This is the dome of my hometown, Florence, and Thank you for your attention.
We have time for questions. Any questions? Somebody want to kick us off? Steve.
So that was beautifully spoken and beautifully presented. Thank you very, very much. You spoke about disease-free survival, and you spoke about the survival as such. And you had a statement that it was safe and well tolerated. But what was the incidence of side effects like bronchiolitis obliterans, cardiac toxicity, hepatitis, renal failure? What other morbidities are associated with the treatment that are long-term?
I should have said Dr. Child.
The incidence like in any procedure, you have an early toxicity and a later toxicity. The early toxicity is strongly dependent on the screening of the patient. So if when we transplant an autoimmune patient, we have to adequately screen, even if it's completely asymptomatic. We screen them from a cardiological point of view, functional respiratory tests, whatever, in order to exclude a comorbidity. In my opinion, an MS patient should be excluded if there is a comorbidity. There are some diseases in which this is more difficult. If you treat a scleroderma patient, that is a horrible disease, an autoimmune disease with a deep involvement of heart and lungs, and many patients can die of the progression of the disease. So in this case, we cannot exclude them because of the comorbidity which are part of the disease, not in MS. So in MS, let's say if you screen the patient and you take care of, let's say, to apply a number of technicalities, which was too long here to do. For instance, so we protected the bowel. We see that patients, especially with spinal cord lesion, develop almost always some constipation or diarrhea, which can be very discomfortable. So we switch to total and parenteral nutrition and intravenous treatment. We put the bowel at rest. The bladder, many MS patients have a dysfunction of the bladder, which expose them to the risk of a toxicity in the bladder of the chemotherapy, because the bladder doesn't get empty. So we put a bladder catheter during the administration of chemotherapy, and so on. Another important point is a viral reactivation. Sorry, there is an answer from a question from a doctor, an answer to a doctor. So it's a bit technical. So there are many of these patients, probably to the use of the ATG in the conditioning regimen, develop a reactivation of virus, in particular cytomegalovirus and ABV. So it's quite important to make a test and look at the viral load in the 3 months after the transplant, and to apply a preemptive treatment in case of severe reactivation before that the viral makes develop the disease. With regard to the long-term, so let's say most of early complication can be controlled with an adequate selection of patient and medical care. The long-term complication might be related also to the intensity of conditioning regimen. So far, the most frequent complication is a secondary autoimmune disease, but which is mostly thyroiditis, which is about 5% of patients develop a transient thyroiditis in the 2-3 years after the transplant. I have to say that in some cases, a thyroiditis was present at the moment of the transplant, which was not diagnosed. So when we started to see the secondary, we thought, thyroiditis, we started to require a thyroid screening in MS patients at the moment of transplant. We found that some of them had already a thyroiditis unknown. The most relevant, of course, let's say, problematic complication might be a secondary malignancy. So we try to compare a patient with MS and in the incidence of secondary malignancies, let's say malignancies, after the transplant with patient with MS from the registry. So the incidence of relapses of secondary malignancies in normal MS patients, and also in patients who had the same conditioning regimen, but for lymphomas. The incidence of malignancies is very low. It's below 1%, so it is confounded in the background. We cannot say so far that the transplant results in a higher rate of secondary malignancies, but we had to wait many patients for a long time. So far, we don't have that evidence of a trend in that. So, just to answer your question, most of the side effects can be controlled.
Thank you. If I've understood you correctly, you said that this is a very effective treatment. It's actually better than D&Ds in many cases. And yet, if I heard you correctly, you said that you should only have this treatment in an experimental situation. Many people, my daughter included, didn't want to wait. And so they've gone and got the treatment elsewhere. If your daughter could not get the treatment in your country and you know the evidence, wouldn't you go and support her to do that?
So, first of all, I have to declare my conflict of interest. This stem cell transplantation in multiple sclerosis has been my project since 20 years. So definitely I'm favorable to that. Part of the jokes. Yes, if I would say that my daughter would continue and progress and develop new relapses despite the administration of approved treatment, I would support it. The choice of the center can be problematic.
Yeah.
But this is another issue. Once again, in my opinion, today we have enough scientific evidence that the procedure should be approved by the competent authority as a clinical option, not as a treatment of MS, which is another thing, but as a clinical option for those patients who fulfill those criteria. In that boost of transplant which happened, that I show you in Sweden, where the result of a document of the statement of the Swedish Medical Health of Ministry of Health, which approved the transplantation like that, so as a possible or clinical option for MS patients. So that means that it was reimbursed by the national health system, and that transplanters and neurologists could screen patients to be transplanted in the, let's say, framework, in the context of a treatment, extended treatment panorama. So this is what most authorities should do now, also to avoid that a patient is obliged to migrate somewhere else. I don't know which is the situation in New Zealand. Tomorrow I'll give a presentation to this hospital, Auckland City Hospital. So I will ask to the neurologist which is their position.
Could you expand a bit on your list of criteria, the weighting you put on the need to fail approved existing therapies when the results you presented on the NEDA slide, I mean, interferon is effectively no better than a placebo, and the next generation are at best 50-50. Why is that such a key criteria to have failed those when that just burns up time?
Well, we wrote high efficacy. Was a recent paper which divided the treatments approved for MS in low efficacy, such as interferon, and a high efficacy, including Tecfidera, Tysabri, Lentrada, and probably now ocrelizumab. Some neurologists now look at the clinical onset of the disease, and in case of a very aggressive disease, they immediately start with a high efficacy treatment. Personally, I do not accept a patient who just failed interferon. This is a long conversation that I have with a neurologist. Every time they propose to me, or I propose to them a patient who failed interferon, and they say, well, interferon, okay, if you think it's so ineffective, why do I administer the interferon to these patients? Anyway, this is another thing. So, in my opinion, if the patient has failed one line of a high effective treatment, that's enough to go to the transplant, comparing the data. The problem that I personally have is sometimes it happens that a young patient comes to me with an aggressive form of MS. Maybe it is a highly educated patient who read the scientific papers and says, I look at the papers of the neurologist and I know that I have a high annual rate of relapses. So I have an aggressive form of MS. That means that I have a high probability to be worse than now in 5 years. So why should wait to need a stick to walk to get to the transplant? That's a difficult question to answer. So we still stick to the rules. So the patient has to have failed at least one line of treatment. In some cases, if a patient failed Tecfidera or Gilenya, so not Lentrada, we accepted the patient if the clinical picture clearly showed a very aggressive form of the disease with an accumulating number of lesions, possibly enhancing the contrast in the last year. There is another topic, which is the treatment, conventional treatment. I have a biological effect which goes beyond the withdrawal. So there might be the risk of an overlapping of the immunosuppression of the drug and the transplant. This is why we ask always a washout period of at least 3 months for less intense treatment like Copaxone or interferon, Gilenya, Tecfidera, and 6 months for Tysabri and ocrelizumab. I personally ask 1 year after Lentrada. Lentrada is a very effective drug, loaded with some, almost 50% of thyroiditis with time. The risk is that the patient develops relapse as a sort of rebound after the withdrawal of the drug. So we have to develop strategies to keep down the disease in the interval between the suspension of the drug and the transplant. This is still ongoing. I have discussed it recently with Richard Burt, and we have, by the way, the same approach, 6 months of treatment or withdrawal, of, let's say, washout is necessary.
Christian? Right. Thank you for that. Do you have any evidence that some of the commercial transplant agencies available internationally are carried out in an unsafe way?
No, because they do not report their activity in the registries. They do not publish their data, so nobody knows what they do. Sometimes I have some information from patients who did the transplant elsewhere. a question of many patients is if a patient relapses, can we do the transplant again? I said the relapses are very infrequent. Usually they are well responding to conventional treatment. In my experience, I did a second transplant from a patient who had received a transplant in another center, not those one reporting to the registry, probably with a very low intensity regimen and plasma mesenchymal stem cells, and she relapsed soon after the transplant. So, no, we can't say this is an old issue. Usually in the Western world, all centers have to report to a registry. They have to report to the competent authority, and in some cases, there is a benchmark of the performance of the centers, which should be public. So if a center doesn't report their activity anywhere, we don't have any information to what they do.
I'm very conscious that Dr. Riccardo is meeting a niece who lives in Auckland at
No, it's okay. I'm happy to get...
We just...
don't worry.
2 or 3 quick questions.
There's a couple of questions over that side.
Over the back there, yes.
Thank you very much, Riccardo. Just 2 quick questions. Have any of your studies or studies around the world with HSCT been in combination with intensive rehab afterwards?
With intensive?
Intensive rehab, so physical therapy,
yes.
afterwards. And because it's such a high level of chemo, more than some of the normal cancer treatments, is there any recommendations of how long there is a rest period before someone would start intensive therapy?
I think that physiotherapy has a crucial role. Many of these patients develop some weakness after the chemotherapy. And if they come from a very intense inflammatory activity, to shut down the flare can result in a sort of shock. So we started the physiotherapy during the admission, just to keep let's say the muscular tone, and right after the discharge, let's say 15 days after the discharge, they start to have physiotherapy. The physiotherapist, in some cases, tend to correct to them the defect that they have accumulated to compensate the neurological deficit. So let's say it's like they teach again to how to walk, and I think that the improvement, the long-term improvement that we see after the transplant are related more to the physiotherapy than to the drug. The early improvement is related to the anti-inflammatory activity. We remove the edema from the brain when they have a recent relapse. The 6-month improvement is related to some remyelination, which is a physiological process which occurs after the transplant. But the long terms are more related to the physiotherapy than to the medicine.
Great news for physiotherapists, There's a question here.
I just wanted to know, if you took the proportion of patients that had bone marrow transplant, what portion of those would be progressive patients, or secondary progressive, for example, patients who have never tried any disease-modifying treatment, and what's their recovery possibility?
In the first 10 years of activity, as I showed in my slides, 80% of patients were in the secondary progressive phase. The results are not that bad, but also because probably some of them were already in the secondary progressive phase, but still with some inflammatory activity. Today, we transplant most of patients in relapsing remitting phase, but of course the follow-up is shorter because we transplanted most of them more recently. The problem is, one of the problems that I would like to try to solve, I'd say to approach, is the problem with the so-called primary progressive patients. There are, conventionally, neurologists say there is nothing that works in this patient, but actually some of these patients develop very rapidly a severe disability. So it's hard to think, and I was discussing that with Jack and Tell in Sydney last week. It's hard to think that these patients do not have any type of flare. Maybe they don't have that conventional flare that we see with the lesions, the relapses, and so on. Maybe the inflammation is more restricted but diffuse in the brain. So we are thinking of developing a protocol to select some patients for primary progressive disease and try to start a trial with them. However, today, in the rough number of 1,000, I would say about 60% were in the secondary progressive phase, but most of them transplanted more than 5 or 6 years ago.
So would they have that same disability, or would they recover well, generally speaking?
They tend to stabilize for roughly, they tend to stabilize for a couple of years, and then slowly they tend to progress. Maybe they progress a bit more slowly than before. When I showed that curve to the neurologist, many of them say, it's not surprising for me that relapsing remitting patients are doing so well. What is even more surprising to me is that the secondary progressive are not doing that bad as expected. But
Okay, last question.
no, there was another question here.
So those clinics that you are authorised type thing, how do you get to one of them? How do you apply? Do you have to live in those countries, or can we apply to that country for treatment?
We have patients, I would say we have 60% of patients from Italy and 40% from abroad, either from Europe and from overseas. It's the same approach. We screen the patient, we treat the patient irrespective of where they come from. Italian patient, for Italian patient, the procedure is paid by the National Health Service. Patient coming from abroad, they have to pay the procedure. There is some German patients, one of the first German patients that we did, they did a class action, and they succeed in having their procedure at least partially reimbursed by the insurance. So there was a trail. This patient was a lawyer, so he put together other patients who did the procedure in our center. They applied, they did the legal action, but they succeeded in having the procedure reimbursed. So I think it's
really expensive.
I think we worked out it was about 115,000 New Zealand dollars, 70,000 euros, you said?
70,000 euros in Florence, about, to my knowledge, about 100,000 euros in Sweden and in Germany, less in UK, about 60,000.
So is that start to finish? Is that all in? Or would there be expenses on top of that? Just your normal... Do you understand what I'm saying? Once you've paid for that, that's all the treatments.
Yes.
Follow up and...
That's for a holiday of 8 weeks.
I don't think it includes your airfare or something.
No. We have an agreement with let's say it's in Florence. So we have an agreement with a charity association, the Leukemia Society, and they give for free a room, 2 rooms to patients coming from abroad, large rooms so the patient can stay with with a relative or in a way a caregiver. Usually patients coming from Europe, they come from the first part, mobilization and collection of stem cells, which takes about 3 weeks, and then go back home, and then return 3 weeks after to do the transplant. Patients traveling from overseas tend to remain in Florence, also to avoid the cost of the travel. So the whole procedure, let's say, from the beginning to the end, including 2 weeks, I always ask the patient to remain in Florence for a couple of weeks after the discharge, just to have them close to the hospital in case that something happened. So the whole procedure takes about 2 months.
Sorry, last question here.
So I think what I've been doing is a remission, no medication, so no chances of doing the stem cell, qualifying for that would be zero. I need to get worse before I could maybe get better. Is that what you're saying? In New Zealand, especially.
Apologize for the quality of my English, but I didn't catch completely. So in case that you don't have any treatment, a disease-modified treatment for...
So I don't qualify for any treatment. So because I'm not being treated with medicines, I wouldn't qualify to do stem cells. Is that what you're saying? I wouldn't have enough.
No. The one obligatory point is that you have to have failed at least one line of approved treatment. So my question is what? You do not qualify for the DMD for some reasons. So, I mean, let's put it like that. If a patient qualifies for the transplant, I would say automatically has to qualify for some of the approved drugs. It means that it has an inflammatory disease, new lesions, relapses, and so on. So therefore, it has to qualify for the approved treatment. If once it is started and with enough time to see the efficacy, you cannot start Tysabri and you have a relapse 20 days after the first administration. It's too short. You have to wait at least 3 months to say that the drug has done his role. So if you fail after an efficient, let's say, administration of an approved drug, then you can qualify for the transplant.
Thank you, Riccardo. Just ask Ingrid Minette, General Manager of MS Auckland, to propose a vote of thanks.
Thank you. Thank you. I have the honor of thanking Dr. Riccardo Saccardi and his lovely wife for coming here today. But before I do that, I just want to say very quickly a big thank you to all of you. And just a reminder that MS Auckland is here for you. So please communicate with us. Let us know, what programs and services are we hitting the mark, or are there other things you'd like to see? Because if we don't hear from you, we don't know if we're doing okay. I also want to say that we've got 4 of our field workers back there. We only have 4, and they're all here. So hopefully you know them. Andrea and Diane and Diane, can you stand up? And that you're in communication with them. Talk to them, let them know if there's things you'd like to see or do. We have 3 of our committee members here, besides Neil, our president. We've got Joan over here, Robert over there. Stand up, people. They're on your committee. They support us in our work and give us advice and stuff like that. We have an AGM every year. We'd like you to come out, and if you would like to get involved in the committee, we'd love to see you. We also have Dr. Ernest Willoughby in the back. He's one of our honorary patrons, a life member, so we're pleased to see you here as well, Dr. Ernest Willoughby. Yeah.
Sorry, I didn't realise that Dr. Willoughby was here. He must have I just want to announce that at the MS New Zealand AGM yesterday, Dr. Edie Willoughby was made a life member of MS New Zealand. And that represents 40 years of service to people with MS in New Zealand, and I'm delighted to convey the news in this audience here.
I know you probably all want to get home, so I will just do the honors and present this gift to both of you. Claudia, you know, beside every good man is a good woman, right?